this decline of the fertility period or the fertility issues, how you correlate with the aging and fertility?
That women are born with finite number of eggs. 20 weeks of gestation, she only has 6 to 7 million eggs.
Do you think like aging is also affecting the endometrial thickness or the vascularity?
Because of the continued oxidative stress, there is a decrease in the blood flow in the endometrium.
This artificial intelligence in recent era, if you'll see, have from the all perplexity to the chat GPT to the everything. Do you think in fertility management artificial intelligence are playing the role? Hello everyone. Today we are having the wonderful guest with us, Dr. Garima Aggarwal. She is a Obs-Gyne and a reproductive medicine specialist trained from the Indian College of Obs-Gyne, ICOG, as well as she is a aesthetic gynecologist practicing stem cells, regenerative medicine, PRP, and various advances in gynecology and the fertility. So today we are going to discuss about the fertility and the regenerative medicine. So welcome you, Dr. Garima, today.
Thank you so much, sir, for a very wonderful introduction. I'm looking forward to a great, fascinating session with you.
So as you know, this is the fertility management, the terminology and the way we have seen the infertility when the IVF has started almost 3 decades back or the 4 decades back, and this journey from IVF to the ART and then donor egg, surrogacy, various things, and recent advances now is the regenerative medicine,
Stem cells and regenerative
stem cells,
medicine.
PRP, etc. So now how you say like this decline of the fertility period or the fertility issues along with the age, how you correlate with the aging and fertility?
This is a very wonderful question, sir. I would like to say that women are born with finite number of eggs, which means that at the 20 weeks of gestation, she only has 6 to 7 million eggs, which rapidly decline when she's born. At the time of birth, only 1 to 2 million eggs remain, and by puberty, only 3 lakh to 4 lakh eggs remain. So as we progress in age, 1,000 eggs are declining per month, each month of the menstrual cycle. Also, as we age further, there is more of oxidative stress, there is more mitochondrial damage at the cellular level, at the DNA level, which leads to a decrease in ovarian reserve and ovarian follicle count, and hence contributing to infertility with age.
So definitely like aging is directly proportional to the fertility periods.
Absolutely.
So this is one of the problem like ovarian aging, we can say. What about any challenges with the, like we always say, like menarche to menopause, like do you think like aging is also affecting the endometrial thickness or the vascularity?
Yes, sir. As we are aging, because of the continued oxidative stress, there is a decrease in the blood flow in the endometrium, which leads to a decline in endometrial thickness, and hence there is difficulty in embryo to implant in the endometrium.
And these days, like when these advances came, like the today's theme is about the regenerative medicine. This word regenerative medicine these days is a buzzword in the fertility management, especially for the thin endometrium,
Yes.
Esselman syndrome, premature ovarian failure, or so-called terminology like ovarian rejuvenation or the early menopause or the perimenopause or the menopause. So what you think about this regenerative medicine? What exactly it is?
So, sir, stem cells and along with PRPs, platelet-rich plasma, platelet-derived growth factors, stem cells along with a combination of these growth factors, when injected into the ovaries, it leads to better ovarian rejuvenation and in a better ovarian hormone environment. And hence it leads to a better follicle formation, better follicle maturation, and also as we age, we reach menopause, there are many dormant and resting cells. So those dormant and resting cells have the ability to respond to the external hormonal stimulus once you give them the stem cells and the growth factors. That is what we mean by awakening of the ovarian or the ovarian rejuvenation.
This regenerative medicine, friends, if you'll see like these days, the way this word had taken the leap in last 2 decades and especially in the fertility since 2007 to till date, if you'll see starting from the platelet-rich plasma to the BMAC, bone marrow aspirated concentrate or bone marrow derived hematopoietic stem cells, or the adipose, the most waste of the body, like fat, from the fat like nanofat or SBF or mesenchymal stem cells, and various perinatal biologics like amniotic fluid, amniotic membrane, or this kind of mesenchymal stem cells, and in futuristic maybe the iPSC, induced pluripotent stem cells. This is going to lead the future of the fertility?
Absolutely, sir. This is leading the fertility game now. The PRPs and the stem cells are very much in demand, very much in vogue, and actually helping the women. So I'd like to ask you, Dr. Prabhu, how is PRP benefiting our patients in the fertility arena?
So, as a scientist, as a researcher, we have seen the platelet-rich plasma. First of all, these days, if you'll see the people, most of the time they're confused about the PRP. They are just thinking like taking the blood, centrifuging and using the plasma. So there are very technical terms. Although this video is intended to the practitioners, definitely the gynecologist as well as the layman. So for layman, it's just taking the blood, centrifuging, separating the RBC and taking some growth factors from the plasma, and then gynecologist inject with histoscope, one of the like so-called like durbin wale surgery jo log kehte hain.
Minimally invasive.
So minimally invasive surgery, or like histoscopically inside the endometrium, like subendometrial injections. So PRP is basically, it's a cocktail of growth factors, various growth factors like alpha granules, dense granules, and these growth factors is working like a fertilizer. It overall giving the effect of the manure effect, like it giving you various kind of growth factor which gives you the better blood vessels formations, then they increases the thickness in that case.
Right.
So these all things. Similarly in the ovary, like so-called like ovarian rejuvenation. But as in scientific experience, I'll tell you, PRP role in ovarian rejuvenation is very dicey.
Very dicey.
Especially if we'll talk about the POI, primary ovarian insufficiency, where the FSH are elevated and all. In that case, you can go ahead with the PRP. But if we'll talk about the premature ovarian failure and your expectation is the fertility, especially you are dealing with the, like after that you are trying to go for the natural conception or the IVF, then PRP is not a good option. PRP we have not seen like increasing the AMH level and bringing the various drastic changes in there. Yeah, but overall you can see like overall improvement into the follicle quality or the microenvironment. But still, if you are preferring and choosing in between of the stem cells and the PRP for ovary, stem cell will be the preferred options. But definitely it's a lack of the larger studies. There is worldwide, still it's a very small case papers are published.
Yes. And which age bracket would you like to give the PRP or stem cell therapy for a better outcome? Which age
definitely
bracket?
if we talk about the ovarian issues like ovarian rejuvenation or the primary ovarian insufficiency, ideally is up to 40 as per the Bologna criteria, or up to 45 you can go. For definitely for endometrium, again it's like same way, like as early much more beneficial.
Yeah, 35 to 40 is
35
a better
to 40 is the
age
better
bracket.
30 to 40, yeah.
After 40 it is, the outcomes
yes,
are very
that's why
dicey.
we always say like if you are marrying late, as a gynecologist we all like you should promote like go for the oocyte preservation.
The earlier the better.
Earlier the better. So
better.
This is the one of the, but definitely this regenerative medicine bringing a paradigm shift in the Obs-Gyne and the fertility practice.
Absolutely, sir, absolutely. That's the only hope right now.
And apart from that, you have raised one very nice question about the endometriosis, what can be done. One of the debilitating conditions, especially if we'll talk about the endometriosis or the painful conditions,
where the doctor and the patient both are helpless. Endometriosis is that kind of a condition.
So recent studies we have started on that. So most waste of your body, the fat. So take the lipoaspirate, make some cocktails, growth factors, it's called SVF, stromal vascular fractions, by mechanical disintegration, and then you during the surgery, when you are doing that, you can do at the intralesional and intraperitoneal injections at multiple sites to prevent from the recurrent adhesions, as well as you can do the because it does the immunomodulation and having the property of anti-apoptotic, anti-fibrotic, immunomodulatory properties. So no, pluripotent is different thing. So immunomodulatory here, it's down-regulate all Th1 cells here. So in that case, basically it prevent you from the recurrent adhesions as well as inflammatory marker subsides.
It works at the molecular level.
Molecular level or in the cellular level. So pain goes, you can check the pain on the visual analog scales and all. So these all things are advancing the endometriosis with regenerative medicine.
So, Dr. Prabhu, I'd like to know what's the difference between using one's own stem cells versus donor stem cells?
So currently own stem cell is called autologous and
Right.
donor is the allogenic. So allogenic is only permissible for bone marrow transplant like hematopoietic stem cell transplant in leukemia or any blood related disorders like thalassemia, sickle cell anemia, AML, CLL, etc. Majorly non-hematopoietic usage you do the autologous, that is the patient own stem cells, either from the blood, either from the fat, either from the bone marrow. So these all are the autologous. Even for the fertility like Asherman syndrome or the this premature ovarian failure, various study if you'll see it's from the own bone marrow. And bone marrow is like, it's not like that you are going to take the 300 cc of the bone marrow, it's like 20 to 30 cc, 40 cc of the bone marrow you need, either from anterior superior iliac spine or the posterior iliac crest. So this again not going for the sternum or the tibia. So this is all the sites. So ideally autologous is patient own stem cells, and majorly in gynae you do the own stem cells.
Own stem cells. And there is less fear of rejection, less immunomodulation once you are using one's own stem cells.
Yep. Dr. Garima, what do you think about this lab grown or the artificial egg or these days ovarian transplant?
Ovarian transplant?
Transplant.
Yeah, I'd like to focus on the ovarian transplant because there is so much happening, for example, especially in cancer patients. Before the cancer treatment begins, before any chemo radiation therapy begins, it's important that we harvest the happy, good ovarian tissue laparoscopically from the patient, which means that we take only the ovarian cortex in thin slices of 1 to 2 mm and we cryopreserve the tissue in liquid nitrogen. That whole process has to be done very neatly, then only it can be beneficial. And once all the cancer is gone from the body, once the immunotherapies are over, then we can transplant this back either in the ovarian fossa or in the subcutaneous arm or abdominal fat area. And the studies say that there is 100% restoration of the endometrial endocrine capacity of the ovarian transplanted tissue.
So how successful it is?
So the endocrine capacity of the ovarian transplanted tissue is 100%. But how much does it result in a positive pregnancy? That is roughly 50
And
to 80%.
how widely is practiced in our country?
Oh, in Delhi NCR, it is being done almost in all good hospitals.
Ovarian transplantation.
Ovarian transplantation.
And it's a fully
yes.
safe procedure, sir.
It's a safe procedure, absolutely.
And these
It's
days,
a breakthrough procedure.
And these days there are various buzzwords, like if you'll see like longevity, anti-aging, ovarian aging, and many of the drugs. So apart from this, like stem cells, PRP, regenerative practices, do you add some supplementation and nutraceutical in your practice or not?
Yes, we give nutraceuticals, we give antioxidants, multivitamins to the patient. We give medicines which increase the blood flow to the endometrium.
Now, if we'll talk about the nutraceuticals and the supplementation, what kind of supplementation you add?
Like DHAs, like vitamin C, like vitamin D. So vitamin D has a proven efficacy in PCOS patients or in patients who have a very high AMH, that is anti-Mullerian hormone. So vitamin D helps in fertility very much.
And some anti-aging drugs or longevity drugs these days,
Like
rapamycin or the resveratrol, glutathione,
glutathione.
N-acetylcysteine, L-carnitine. What's your comments on that?
We can use them, but proven effects are with vitamin D, ecosprin, and vitamin C, I'd say, and DHAs.
Yeah, but definitely these drugs are bringing much more hope for that, and especially rapamycin is well-known anti-aging drugs
Rapamycin is
these
the new
days.
drug.
And definitely the resveratrol, like it's a, we always say like fine wine aging, so it's like all wines giving you the resveratrol, but doesn't mean like going for the wine to have the management.
So women can have the wine.
Yeah. So definitely this. And this artificial intelligence in recent era, if you'll see, have dominated the every area of the life.
Correct, absolutely.
Every day, everything's like, see, from the all perplexity to the chat GPT to the everything, artificial intelligence have dominated in other way. Do you think in fertility management, artificial intelligence are playing the role?
Yes. So AI has a big role to play, especially from the start, how I tell you. So it helps us in finding out which patients will be benefited the most. For example, AI can integrate the hormonal calculation of the patient, the hormonal capacity of the patient, the ovarian reserve, the antral follicle count, and the ultrasounds that are done with the patient. It can integrate it with the history and tell us, guide us, which patient will be benefited the most.
Very true.
Also, in endometrial receptivity, there are AI models and tools which can correlate the endometrial receptivity of the patient with genetic expression and tell us through the ultrasounds how is the blood flow going and will embryo transplant be successful or not.
Very true. Similarly, like in DNA, yeah.
Also, there's one more thing. This is called time-lapse machine. So time-lapse machine analyzes all the embryos which are growing in the machine. Every day, every hour, every minute, it is analyzing which embryo is growing up to what stage, how much it is maturing, and which will be the most successful embryo to be transplanted. And also, there is automated sperm machines, automated sperm analyzers. So they have a very good capacity in counting the sperms, in checking their morphology and motility, and guiding us which kind of IVF
either
treatment.
It's a fragmented or not, DNA fragmentation, they can check.
DNA fragmentation, which the manual lab person will be difficult.
Yeah, like, and it will help in selection of the quality of the eggs, especially for the, like, once you are doing the ICSI, morphological selection,
or
IVF, etc.
Which procedure will benefit the patient, and hence the cost will also come down through AI.
And artificial intelligence, if we'll talk about the regenerative medicine, like, definitely this is revolutionizing, not only for the PRP or bone marrow stem cells. The next era is coming, like the iPSC, induced pluripotent stem cells. There is a future for ovarian rejuvenation, if we'll talk about taking the ovarian biopsy, culturing the oocytes, oogonial population of the cells, and then selecting it and going to implant that directly to the ovary. This is the future of ovarian regenerative practices.
It's the future.
And this is going to revolutionize with the induced pluripotent stem cells. And induced pluripotent stem cells have changed the entire regenerative medicine field, because that led to the Nobel Prize to the Sir Jordan and Shinya Yamanaka from Japan in 2012, when they got the Nobel Prize for the invention of this story of this iPSC, induced pluripotent stem cells.
It's very fascinating and very innovative.
Yeah, it has changed widely the perspective of regenerative medicine.
Completely
iPSC,
changed.
CAR-T therapy is coming, genome editing tools. Now nanomedicine have come, like exosome therapy, nanovesicles, EMB, various things are adding day by day. See, like we are doing today is not the topic of this, but PROM. Pre-viable rupture of the amniotic membrane. Like, patients are coming like 22 weeks, 24 weeks.
Yes.
First time in the world, along with the Dr. Soumya Dinesh, our colleague in Mysore, we have reported and used the own platelet-rich fibrin and PRP to seal the leak.
Wow.
In 22 weeks, and this paper we have published, this study we have published. So this kind of revolution we have brought, and we are leading the world in regenerative medicine, in fertility management.
Wonderful, sir. That is absolutely commendable, the work that you did.
Thank you.
Very impressive.
Thank you, Dr. Garima, for joining my YouTube channel, AgehackR. This is my dream. Like, AgehackR is a name, so it's not like that we are going to hack something. It's AgehackR. The concept is how to bring the longevity and the age management with the preventive regenerative medicine and functional medicine. And today our guest was Dr. Garima Aggarwal, and one of the leading Obs-Gyne and the fertility specialist. Pleasure to have you today. You have shared amazing experience with our audience about the fertility management of the thin endometrium, Messerman syndrome, premature ovarian failure, endometriosis, PCOS, how you can change in your lifestyle, how you can incorporate the newer and innovative technologies like stem cells and PRP, and definitely what you are having in your hand is an holistic approach to do the exercise, have proper sleep, eat nutritious food, and limit your alcohol, smoking, or better, quit smoking and alcohol. And the most important is the exercise. Thank you for sharing this insight to all our audience of the AgehackR, Dr. Garima. Pleasure to have you today with us.
It was a pleasure for this conversation, and the futuristic approaches that you're working on and your scientific approaches, both are path-breaking, and our fertility potential will definitely increase because of your experiments.
Please follow and subscribe our YouTube channel AgehackR, AGEHACKR.
And please look forward to part 2 of the conversation, which will be on aesthetic and regenerative gynecology.